السلام عليكم. أنا دكتور وائل عطية. النهاردة هشرح لكم Congenital Cyanotic Heart Diseases. First of all, let's define cyanosis. Cyanosis is loose discoloration of skin and mucous membranes, where the saturation of a patient is less than 85% by pulse oximetry. If it's only present in the extremities, we call it peripheral cyanosis. If I can detect it all over the body, especially in assessment of the tongues, then it is central cyanosis. It's important to know how to elicit cyanosis. At first, I need to diagnose cyanosis in neonates as soon as possible. And it's very essential that we know that the dark complexion can affect the evaluation of cyanosis. So I need to check the tip of the tongues. Good lighting is important. I need to check in a thermoneutral environment because cold temperature of the room may cause peripheral constriction and peripheral cyanosis. If the child is poorly perfused due to hypoxia or hypotension, may also cause peripheral cyanosis. If I'm doubtful about the saturation of a patient, I need to check with a pulse oximeter or get an arterial blood gas to assess. Usually, a newborn in room air has a saturation of 92 or above, and oxygen tension in the blood gas sample should be more than 60 millimeter mercury. So what are the causes of neonatal cyanosis? First of all, CNS depression. Like in cases of perinatal asphyxia and heavy maternal sedation and intrauterine fetal distress. This is characterized by the baby is having shallow, irregular respiration with poor muscle tone. This cyanosis is correctable when the patient is stimulated or oxygen is administered. Pulmonary diseases of cyanosis includes parenchymal lung diseases like hyaline membrane disease, pleural diseases like pneumothorax or pleural effusion, chest wall diseases, and diseases of the muscle like diaphragmatic hernia. These are characterized by tachypnea and respiratory distress with abnormal breath sounds on auscultation. Chest X-ray may usually reveal the cause. Oxygen administration may improve or abolish cyanosis. Finally, cardiac causes of neonatal cyanosis include cyanotic heart diseases with right to left shunt. Usually there is tachypnea without retractions. There is a lack of abnormal breath sounds unless congestive heart failure occurs. Usually, if heart murmurs are absent, it's a serious form of cyanotic heart disease because usually we have the murmur of a PDA. Chest ray film may cause cardiomegaly and abnormal cardiac silhouettes, increased or decreased pulmonary vascular markings, and in blood gases there is minimal or maybe no increase in oxygen tension. What should I do to assess a case of neonatal cyanosis? First of all, we'll do a chest X-ray to differentiate between pulmonary and cardiac causes. Second, we can do an ABG or a hyperoxia test. It can also help to differentiate cardiac from pulmonary causes. Then I should do a septic screen and a blood glucose assessment because sepsis, hypoglycemia, polycythemia also can present by cyanosis. Finally, I can do an ECG and echocardiogram, which can show the causes, cardiac causes, and can assess also primary pulmonary hypertension of the neonate. What's a hyperoxia test? When cyanosis is confirmed by obtaining an arterial blood gas and the PO2 is less than 60, we can differentiate between the respiratory and cardiac causes of cyanosis by this test. We should administer oxygen at a high concentration, up to 100% to a head box. Then I'll obtain a blood gas arterial from the right radial artery and wait for 15 minutes to repeat the arterial blood gases. If PO2 improves to more than 250, then it's a respiratory cause. If it's still less than 150, it's a cardiac cause. When a patient comes to my clinic, before referring to a cardiologist, I should do the following investigations. Chest X-ray differentiate between reduced pulmonary blood flow and increased pulmonary blood flow. Then, with an ECG showing the different chamber enlargement, I may be directed towards some diagnosis before sending to a cardiologist. So, right ventricular hypertrophy with reduced pulmonary blood flow may be in cases of Fallot. Left ventricular hypertrophy with pulmonary atresia with decreased pulmonary flow may appear in pulmonary or tricuspid atresia. Biventricular hypertrophy in reduced pulmonary blood flow may represent in TGA and Truncus. Right ventricular hypertrophy in increased flow is diagnostic of total anomalous pulmonary venous drainage, or also in TGA with overflow, especially if I have a VSD or a PDA. Here are some common congenital cyanotic heart diseases. So, diseases with increased pulmonary vascular flow, like TGA, TGA and VSD, double outlet right ventricle, TGA, subpulmonic VSD, which we call Taussig-Blng anomaly, total anomalous pulmonary venous drainage, Truncus arteriosus, single ventricle without a pulmonary stenosis. Then we have congenital cyanotics with decreased pulmonary blood flow, like Tetralogy of Fallot, double outlet right ventricle with pulmonary stenosis, Ebslein anomaly, pulmonary atresia, tricuspid atresia, TGA and PS, and single ventricle in presence of pulmonary stenosis. Then let's discuss different types of congenital cyanotic heart diseases. The most famous disease, the Tetralogy of Fallot, it represents 5 to 10% of the all congenital heart diseases we know. Probably the most common type. The pathology is infundibular PS, aortic overriding, a VSD, and a right ventricular hypertrophy. Patients with Fallot tetralogy usually present with cyanosis at birth or shortly after. They will present with dyspnea on exertion due to hypoxia. They may present by hypoxic spell and sweating. In patients with acyanotic Fallot, patients may be asymptomatic. On physical examination, there is variable decrease of cyanosis, tachypnea, clubbing. We can elicit systolic thrill on the precordium in the upper and mid-left sternal border. We can elicit a single S2 because of the muffling of the pulmonary component of S2. There is a loud ejection systolic murmur of the pulmonary stenosis on the mid and upper left sternal borders. With more severe obstruction of the right ventricular outflow tract, the murmur may get shorter and softer. Investigations in a case of Fallot tetralogy include ECG, which will show a right axis deviation and right ventricular hypertrophy. A chest X-ray will show a normal-sized heart with decreased pulmonary vascular marking, the characteristic boot-shaped heart or Coron Savou of the Fallot tetralogy due to a small main pulmonary artery and upturned apex. There may be right atrial enlargement or right aortic arch in some cases. Echocardiography will show the characteristic pathology of the Fallot tetralogy, and cardiac catheterization is only reserved for selected patients. What is the fate of a patient of Fallot tetralogy if left untreated? First, cyanosis will progressively increase as the infundibular stenosis will worsen by time, in addition to the developing polycythemia. Polycythemia will develop secondary to prolonged hypoxia. There may be a relative iron deficiency, which means the patient with a Fallot tetralogy may not have the elevated hemoglobin and hematocrit as expected, and this should be considered some form of a relative anemia with iron deficiency. Patients with Fallot tetralogy may present with hypoxic spells. They may present also with growth retardation, especially with severe cyanosis. They are at risk of developing brain abscesses or cerebrovascular accidents. They are also prone for endocarditis and coagulopathy. So, one of the most serious complications in a patient with Fallot tetralogy is hypoxic spell. Hypoxic spell, which is also called cyanotic spell or TET spells, are characterized by paroxysms of hyperepnia, irritability, prolonged crying, increasing cyanosis, and decreased intensity of the systolic murmur. A severe spell may lead to serious CNS complications, lameness, convulsions, cerebrovascular accidents, or even death. There appears to be no relation between the degree of cyanosis at rest or the likelihood of having hypoxic spells. The patient may be presenting with saturation of 80s and still has serious spells as serious as patient with saturation 75. This slide shows the hypoxic spell. With a hypercyanotic spell, there is infundibular narrowing, reducing the flow in the main pulmonary artery, and decreases oxygenation, shifting more blood towards the aorta, which increases cyanosis, hypoxia, and acidosis. This will start a vicious cycle that increase more the infundibular narrowing and just increase more the cyanosis and acidosis and so on. This will result into tachypnea, disappearance of the ejection systolic murmur of the pulmonary stenosis due to the outflow obstruction, and this may lead to death. Treatment of hypoxic spell should break a vicious cycle of the spell by, number one, a knee chest position where we increase the systemic vascular resistance, shifting the blood more towards the RVOT. Morphine sulfate, which decreases the irritability of the patient. Oxygen improves the hypoxia. Sodium bicarb to improve the acidosis. If these measures are not enough to control the spell, we can give IV propranolol that reduce the heart rate and reduce the infundibular narrowing, and we can also give ketamine that increase systemic vascular resistance and sedate the patient. We can also give vasoconstrictors like noradrenaline or phenylephrine that increase the systemic vascular resistance and shifts blood more towards the obstructed RVT. Medical management of patients with Fallot tetralogy includes the following. Physician must identify or treat the hypoxic spell, and the parents should also know how to deal with spells when they occur at home. Oral propranolol is given to prevent hypoxic spell until the proper timing of surgery has come. Some centers do balloon dilatation or stenting of the right ventricular outflow tract. This improves the pulmonary flow until the patient is ready for surgical repair. Relative iron deficiency should be identified and treated. As for surgical management in Fallot tetralogy, there are palliative procedures and definitive procedure. The palliative procedure includes the Blalock-Taussig shunt, where we create a shunt between the subclavian artery and the pulmonary artery on the same side. This palliative procedure aims to improve the patient's saturation and improve the pulmonary artery size until patient is fit for definitive surgery. Definitive surgical repair in Fallot tetralogy includes VSD closure with a patch, RVUT resection, and pulmonary valvotomy. The timing of the surgery varies from institution to institution, but generally it's preferred to be done early. Indications: whenever oxygen saturation drops below 75 is an indication for intervention, and in most centers, frequent hypoxic spell is an indication for urgent intervention. Symptomatic patients who have favorable anatomy of the RVUT and pulmonary arteries have primary repair at any time after 3 to 4 months of age. Mild cyanotic infants who has previous shunt surgery may be delayed for 1 or even 2 years after the shunt. There is a variant of Tetralogy of Fallot where the pulmonary valve or artery are completely atretic. These represent almost 15 to 20% of Tetralogy of Fallot patients. The pathology is extreme form of Fallot with extreme obstruction of the right ventricular outflow tract. So the pulmonary blood flow is only mediated through a patent ductus arteriosus in 70% of cases, and less commonly there is what we call multiple aortopulmonary collaterals, which are collaterals between the aortic vessels and the pulmonary arteries that keep blood flow to the pulmonary arteries. These patients are diagnosed at birth by severe cyanosis. The severity is dependent on the patency of the ductus or the aortopulmonary collaterals. By auscultation, there is a faint continuous murmur of the PDA and the collaterals, and the second sound is loud and single. ECG and chest X-ray is similar to that of Fallot. Echocardiographic studies shows the anatomy of Fallot plus the absence of a direct connection between the right ventricle and the pulmonary artery. Treatment of these cases includes palliative procedures and definitive procedures. Palliative procedures aim to increase the pulmonary blood flow and allow the development of the PA branches. These procedures include either cardiac catheterization for PDA stenting or surgical intervention by Blalloch Taussig shunt at the Fallot. Surgical repair includes a VSD closure with a patch and resuming the continuity between the right ventricle and the pulmonary artery through a valved conduit, with interrupting the collateral circulation. Then comes one of the most common causes of cyanotic heart diseases with increased pulmonary blood flow, which is the complete transposition of great arteries, representing 5 to 7% of congenital heart diseases. This disease, the aorta arises anteriorly from the right ventricle, and the pulmonary arises posteriorly from the left ventricle, resulting in complete separation of the pulmonary and systemic circulation, which runs in parallel. And to survive, this patient needs mixing on either the following levels: the atrial level, ASD by ASD, ventricular level through a VSD, or by a PTA. Some cases may have VSD as part of their pathology, and some cases may have left ventricular outflow obstruction as part of their pathology. This is a diagram showing the parallel circuits of the TGA, where the deoxygenated blood comes through the superior and inferior vena cava to the right atrium to the right ventricle, and then to the aorta to the systemic circulation. Whereas the oxygenated blood comes through the pulmonary veins into the left atrium, then to the left ventricle, and to the pulmonary artery to go on through the continuous parallel circulation. This results in severe cyanosis, and without any mixing at any level, the patient will not survive. Clinically, this patient presents with cyanosis since birth, and signs of congestive heart failure as dyspnea and feeding difficulties may develop later. By examination, we can elicit moderate to severe cyanosis. The patient is tachypnic with or without retractions, unless the patient will develop congestive heart failure in cases of a large VSD or a large PDA. Second sound is single and loud with no heart murmurs if the ventricular septum is intact. If there is a VSD, we have this pansystolic murmur of the VSD. If we have left ventricular outflow obstruction, there is the ejection systolic murmur of the pulmonary stenosis. If the patient develops congestive heart failure, we can have dyspnea and hepatomegaly. ECG shows right ventricular hypertrophy since early days of life. Biventricular hypertrophy may develop with patients with large VSD or PDA. Chest X-ray will reveal cardiomegaly with increased pulmonary blood flow with the characteristic shape of the egg-shaped heart. Echocardiography will show the characteristic features of the D-TGA. Cardiac catheterization may be needed for balloon atrial septostomy to improve the mixing at the atrial level. It's rarely performed to show associated anomalies like coronary artery anomalies or collateral circulation or small aortic isthmus or coarctation. So what is the fate of transposition of great arteries if left untreated? These patients will develop progressive hypoxia and acidosis and heart failure and results in death within the neonatal period. Most cases, 90%, will die before the age of 6 months. Patients with VSD and PTA are less cyanotic and more likely to develop congestive heart failure, but these patients are more prone to develop pulmonary hypertension and pulmonary vascular disease early by the age of 3 to 4 months of age. So any surgical intervention is recommended to be done before this age. The combination of TGA with VSD and pulmonary stenosis allows longer survival without surgical intervention. However, this is because it is protective against pulmonary hypertension and pulmonary vascular disease. However, this combination carries higher risk during surgical correction. So usually these patients come as an emergency. So at first we need to stabilize the patient before doing any definitive intervention or even palliative procedure. At first, we need to correct the metabolic acidosis. We should start prostaglandin infusion to keep the patent ductus arteriosus patent and improve oxygen saturation. We should administer oxygen once prostaglandin E1 is started to decrease pulmonary vascular resistance and allow increased pulmonary flow and increase systemic arterial saturation. In case there is congestive heart failure in patients with VSD or large PDAs, anti-failure medications should be started. Balloon atrial septostomy, the Rashkin procedure, should be immediately carried out in case of adequate atrial mixing through the PFO, when the patient is presenting with low oxygen saturation and we are not ready for urgent surgical intervention. During this procedure, the balloon tipped catheter is advanced into the left atrium through the PFO. Then the balloon is inflated with dilated radio-opaque dye and abruptly and forcefully withdrawn to the right atrium under fluoroscopic or echocardiographic monitoring. This procedure creates a large defect in the atrial septum and allows proper intracardiac mixing. This will increase oxygen saturation by 10% or more and this will be satisfactory until the patient is ready for surgical intervention. Definitive surgical repair in cases of transpositional great arteries include two types of surgeries. First, the atrial switch surgeries, which are the baffle operations like mustard and Sanning. In these procedures, there is rerouting of the pulmonary and the systemic venous return at the atrial level, resulting in physiological and correction. The pulmonary venous blood is collected through a baffle towards the right ventricle, which, according to the pathology, opens into the aorta, and the systemic venous return is collected through baffles to the right ventricle, to the left ventricle, which opens into the which already opens in the pulmonary artery. Thus, the venous blood goes to the aorta, and the systemic blood goes into the pulmonary. Second is the arterial switch operation, which is the procedure of choice if done in the proper timing. Surgery requires good left ventricular size with good left ventricular mass and no left ventricular outflow tract obstruction. It's essential to do the switch operation as early as possible when this left ventricle is still trained enough to handle the high systemic pressure. The procedure entails mobilization and transplanting the coronary artery to the pulmonary artery, which will be the future aorta, and then the proximal great arteries are connected to the distal end of the other great artery, resulting in anatomic correction. This procedure has the advantage over the atrial baffle operation because it's anatomic correction with less frequent long-term complications. Next, we are going to discuss total anomalous pulmonary venous return. This pathology represents around 1% of congenital heart diseases, in which there is no direct communication between the pulmonary venous system and the left atrium. Instead, these pulmonary veins are draining into the right atrium, and according to this drainage, the defect is divided into 4 different types. The first type is supracardiac type, which represents 50% of total anomalous pulmonary venous drainage patients. The common pulmonary venous sinus drains into a left vertical vein, which goes cranially to connect to the innominate vein, which in turn drains into the right SVC. The second type is the cardiac type. This type represents around 20% of cases where the pulmonary veins enter the RA separately through 4 openings or drain by a common pulmonary venous sinus into the coronary sinus to the RA. The third type is the infracardiac type, which represents around 20% of cases. The common pulmonary venous sinus drains in the abdomen through the portal vein, ductus venosus, hepatic vein, or IVC. This vein penetrates the diaphragm through the esophageal hiatus. The fourth type is mixed type, which represents around 10% of cases. In many cases, there may be pulmonary venous return obstruction, resulting in rapid development of pulmonary hypertension. These patients usually present with pulmonary venous congestion, hypoxia, and systemic hypoperfusion. An inter-atrial communication is mandatory for survival of these patients. The left side of the heart is usually relatively small. The clinical manifestations in these patients differ depending on whether there is obstruction of the pulmonary venous return or not. In case there is no pulmonary venous obstruction, the patient presents like left to right shunt with congestive heart failure, cross retardation, frequent lung infection in infancy, and there may be mild cyanosis starting from birth. On examination, the child is malnourished, mildly cyanotic, with manifestations of congestive heart failure. By local cardiac examination, there is widely split second sound. The second sound may be accentuated because of pulmonary hypertension. There is grade 2 to 3 ejection systolic murmur due to pulmonary overflow. There is mid-diastolic rumbling murmur over the tricuspid area due to increased flow across the tricuspid valve. ECG presents with right ventricular hypertrophy and occasionally right atrial hypertrophy. Chest X-ray may reveal moderate to marked cardiomegaly involving the right atrium and right ventricle with increased pulmonary vascular markings. There may be the snowman sign or the figure of 8 configuration, which may be seen in cases with supracardiac type. Patients with pulmonary venous obstruction present with marked cyanosis and respiratory distress since the neonatal period. Physically, these patients show cyanosis, tachypnea, and retractions in these patients who are malnourished. Chest examination will show the pulmonary crackles, hepatomegaly. ECG shows right ventricular hypertrophy or right atrial hypertrophy. Chest X-ray shows a normal heart size or slightly enlarged, with lung fields showing evidence of pulmonary congestion up to pulmonary edema. Echo examination will show the diagnostic features of the total anomalous with a large right ventricle and compressed left ventricle, large right atrium with small left atrium, and deviation of the atrial septum towards the left side, pulmonary artery branches dilatation. The interatrial communication is necessary for survival, either PFO or ASD. There may be a large common chamber posterior to the left atrium, draining these pulmonary veins. Doppler studies may show increased flow velocity across the pulmonary artery or the tricuspid valve, or even over the pulmonary veins. Echo will also show the features of each type with the common pulmonary venous confluence draining into the specific site, whether in the supracardiac type, the cardiac, or the infracardiac, differentiating the different types. And sometimes we may need other modalities like multi-slice CT angiography to differentiate between different types. So what is the fate of these patients without surgical intervention? Congestive heart failure will develop in all types of total anomalous pulmonary venous return with gross retardation and repeated chest infections. Without surgical intervention, 2/3 of patients without obstruction will die before the age of 1 year, usually of superimposed pneumonia. Patients with obstruction rarely survive more than few weeks without surgery, mostly die before 2 months of age. Management of these cases include medical management with intensive anticongestive measures and diuretics for patients without pulmonary venous obstruction. In case of metabolic acidosis, should be treated properly. Patients with severe pulmonary hypertension and cyanosis may be treated with prostaglandin E1 to keep the ductus open and improve oxygen saturation. All patients with total anomalous pulmonary venous drainage will definitely need surgical intervention. But it is urgent for patients with obstruction they should be operated soon after diagnosis in neonatal period. Patients without venous obstruction can be operated late in the age of 4 to 6 months. The procedures depend on the type of the pathology, and all the procedures intend to redirect the pulmonary venous return back to the left atrium. The next pathology is a tricuspid atresia. Tricuspid atresia accounts for 1 to 3% of congenital heart diseases. In this disease, the tricuspid valve is obstructed with smallish right ventricle. The patient needs an atrial septal defect for survival, plus either a VSD or a PGA. Clinically, these patients present with cyanosis since birth. Tachypnea and poor feeding usually manifest. There may be hypoxic spells like these of the Fallot if the VSD is smallish. Physical examination will show cyanosis, single second sound, pansystolic murmur of a VSD. There may be a continuous murmur of PGA. Hepatomegaly may indicate either an inadequate interatrial communication or may be a sign of congestive heart failure. ECG in these patients shows superior QRS axis deviation, left ventricular hypertrophy, and right atrial or biatrial hypertrophy. Chest X-ray shows a heart of normal size or slightly increased. There is a large right atrium and left ventricle. Pulmonary vasculature may be decreased in most cases. However, in patients with VSD, large VSDs, and without obstruction of the pulmonary outflow, there may be increased pulmonary vasculature. Echocardiography shows the pathology of absent tricuspid valve, large right atrium, and hypoplastic right ventricle, and large left ventricle. In case of restrictive atrial communication, we can demonstrate bulging atrial septum towards the left side. We can also demonstrate the size of the VSD, presence or severity of pulmonary stenosis, and whether there is transposition of great arteries as well. Cardiac catheterization is generally recommended for any patient of tricuspid atresia before planned surgical intervention, because we need to demonstrate specific information like the pulmonary artery anatomy, the mean pulmonary artery pressure, left ventricular function. These are all important pieces of information before front-end surgery. If these patients are left untreated, they rarely survive beyond the age of 6 months. Occasionally, patients with increased pulmonary blood flow, like those patients with large VSDs and unobstructed pulmonary outflow, they will develop congestive heart failure, and eventually there will be pulmonary vascular obstructive disease. Management of these patients involve initial medical management and palliative surgical procedures. First, we should start prostaglandin E1 as soon as possible to improve PDA, improve oxygen saturation by maintaining PDA patency. Then, a Rushkin procedure should be done in cases having restrictive interatrial communication to improve the right to left atrial shunt and improve oxygen saturation until patient is ready for surgical intervention. Surgical management of these patients are usually staged. The first stage is maintaining the good pulmonary flow, either by doing a BT shunt if this patient is having pulmonary stenosis or a restrictive VSD or pulmonary atresia, or we can do a pulmonary artery bending in patients with a large VSD and unobstructed pulmonary flow. Then comes the second stage, which is the bidirectional Glenn operation. This is a shunt between the end of the superior vena cava to the side of the right pulmonary artery. It's usually performed after the age of 3 months. By this time, the pulmonary venous resistance is sufficiently low and allows venous pressure to be the driving force of the pulmonary circulation. So the blood flows from the circulation in the upper systemic veins of the upper half of the body into the pulmonary artery. This procedure usually keeps oxygen saturation around 85% and relieves the volume overload over the left ventricle. The third stage is the Fontaine operation. The original Fontaine operation was an intra-atrial tube that's connecting between the inferior vena cava and the superior vena cava, and the distal end of superior vena cava is finally anastomosed to the outer surface of the RPA in front of the old connection in the Glenn. Another alternative nowadays is an extra cardiac conduit that's connecting the inferior vena cava directly to the right pulmonary artery. The Fontaine operation is usually completed when the child is around 4 years of age, and cardiac catheterization and echocardiography are very necessary to exclude the risk factors for Fontaine operation, because the presence of 2 or more of these factors is a high risk for Fontaine operation. First, a mean pressure of the pulmonary artery of more than 18 millimeter mercury, distorted pulmonary artery branches secondary to previous shunt Glenn operations, poor ventricular function, and AV valve regurgitation. The next defect is the pulmonary atresia with intact ventricular septum, which represents around less than 1% of all congenital heart diseases. In this disease, 80% of cases have pulmonary valve as a diaphragm-like membrane separating the right ventricular outflow tract and the main pulmonary trunk. In 80%, the infundibulum is also atretic. Rarely, the valve ring and the main pulmonary artery are entirely hypoplastic. Usually, the pulmonary artery are confluent, which means both pulmonary artery branches are in direct continuation with the main pulmonary artery. And in such case, the pulmonary blood flow is only provided through a PDA or collaterals. And for survival, a patient needs an adequate interatrial communication and a PDA. These patients present with history of cyanosis since birth. By examination, the patient is cyanotic, tachypnic, with single second sound. There is a soft murmur of tricuspid reverse, or a continuous murmur of PDA may be audible. If the interatrial communication is inadequate, we can elicit hepatomegaly. ECG shows a normal QRS axis, left ventricular hypertrophy, and possibly right atrial hypertrophy. The heart size is usually normal. However, there may be right atrial enlargement. Pulmonary vasculature is usually diminished. Echocardiography is characteristic for disease pathology. Cardiac catheterization may be required for patients of pulmonary atresia to show the right ventricular cavity. Without intervention, the prognosis is very poor. Almost 50% of these patients die by the end of the first month, and 80% will die by the age of 6 months. Management includes medical, cath intervention, and surgical intervention. Once these patients are diagnosed, prostaglandin E1 infusion should be started to maintain PDA patency. Some centers perform PDA stenting, and in other centers, where the pulmonary valve is a membrane, radiofrequency perforation of the pulmonary valve followed by balloon pulmonary valvuloplasty can be used to establish right ventricular outflow tract to pulmonary artery continuity. Surgical intervention depends on the size of the RV. If the RV size is adequate, biventricular repair is usually feasible. If it's not, so the patient goes into the univentricular repair option, ending by Fontaine operation. The next defect is Ebstein's anomaly, which is a disease of the tricuspid valve occurring in less than 1% of congenital heart diseases. The pathology of the disease involves displacement of the septal and the posterior leaflet of the tricuspid valve into the right ventricular cavity, so that a part of the RV is now becoming part of the right atrium. We call it atrialization of the right ventricle. There is functional hypoplasia of the RV, where the cavity is becoming smaller. This abnormal valve is severely regurgitant, and this results in dilated right atrium. There is usually a large AST with a right to left shunt in all these patients. The right ventricular free wall is often dilated and thin. These patients are always suffering from Wolff-Parkinson-White pre-excitation, and predisposes the patient to SVT. A common association with this pathology is pulmonary stenosis or pulmonary atresia, sometimes TOP and VSD. Clinically, these patients present with cyanosis and congestive heart failure since the first few days of life in severe cases. By time, pulmonary vascular resistance may decrease, which allows a more pulmonary flow and decrease of the severity of symptoms. Milder cases may just complain of dyspnea, fatigue, cyanosis, and palpitation on exertion. There may be a history of supraventricular tachycardia. By physical examination, there is mild to severe cyanosis according to the condition. In older children, there may be clubbing. By examination, there is widely split second sound, pansystolic murmur on the tricuspid area for the tricuspid regurg, and there may be also a mid-diastolic murmur at the same location for a relative mitral tricuspid stenosis because of the increased flow across the tricuspid valve. Hepatomegaly is usually present. ECG shows right bundle branch block and right atrial hypertrophy in most cases. Sometimes we can show first-degree heart block. Wolff-Parkinson-White pattern of the pre-excitation can be elicited. Sometimes a patient may present by SVT, and this can be elicited by ECG. Chest X-ray may not show changes in mild cases. However, in severe cases, there is extreme cardiomegaly due to hugely dilated right atrium, and in such case, usually there is decreased pulmonary vascular markers. Echocardiography is the procedure of choice for the diagnosis and assessment of Ebstein anomaly. Cardiac catheterization is not needed. If these patients are left untreated, some severe cases may die in the neonatal period. 30% of patients die by the age of 10 years from congestive heart failure. Patients with less severe anomaly are maybe asymptomatic or mildly symptomatic. However, by time, hemodynamic deterioration increases the cyanosis, congestive heart failure symptoms, and LV dysfunction will develop later in life. Sometimes there are attacks of supraventricular tachycardia associated with WP-WP excitation in 15 to 20% of cases. Sudden unexpected deaths may occur due to arrhythmias. Medical management of these cases includes the following. First, in severe cases, may need mechanical ventilation, prostaglandin E1 infusion, inotropes, correction of metabolic acidosis prior to surgical emergency procedure. Asymptomatic cases may just need regular follow-ups. If congestive heart failure manifestations develop, anti-failure, anticongestive medications can be added. Acute episodes of supraventricular tachycardia may need urgent intervention with adenosine. Prophylactic beta blockers can be added to prevent recurrence. Urgent surgical intervention may be indicated in critically ill neonates who are showing symptoms within the first few days of life. Surgical intervention also may be indicated in cases with progressive cyanosis or congestive heart failure manifestations, right ventricular outflow tract obstruction by the redundant tricuspid valve tissue. If there is a history of paradoxical embolization due to the right to left shunt across the interatrial septum, septal defect, and also in cases of repeated life-threatening arrhythmias. Surgical procedures include palliative procedures for critically ill neonates with failure of medical treatment to avoid death. This includes VT shunt and atrial septectomy when there is obstructive lesions between the right ventricular cavity and the pulmonary artery, or a stenotic tricuspid valve. We can directly proceed to a classic Glenn if the RV cavity is not sufficient and the child is severely cyanotic. Definitive procedure includes either biventricular repair if the patient has a good sized right ventricle and with a good function, or we can perform a univentricular repair when the RV size is not adequate following a bidirectional Glenn operation which was done earlier in life. Other procedures can be done for patients with recurrent supraventricular tachycardia as radiofrequency ablation of accessory pathway. The next effect is a truncus arteriosus. Truncus arteriosus represent less than 1% of congenital heart diseases. In this disease, there is a single arterial trunk coming out from the heart with a truncal valve, giving rise to both the pulmonary and the aorta. There is a large perimembranous VSD direct below the trunk, and the truncal valve may be bicuspid, tricuspid, or quadricuspid, and is often regurgitated. This anomaly is divided into 4 types by how the pulmonary arteries arise from the truncus arteriosus. Type 1 and 2 constitutes 85% of cases, where in type 1, the main pulmonary arises from the trunk and giving rise to both branches, right and left pulmonary arteries. Type 2, both right and left pulmonary arteries arises from the back of the trunk. And type 3, they are arising from the sides of the trunk. Type 4 is not actual a truncus, it's some variant with severe form of Fallot and pulmonary atresia. what we sometimes call as pseudo-truncus arteriosus. The pulmonary blood flow is usually increased in type 1, nearly normal in types 2 and 3, and decreased in type 4. There may be a right-sided aortic arch in 30% of these cases. Clinically, these patients present with mild cyanosis immediately after birth. Usually, there are signs of congestive heart failure within several days to weeks after birth. Usually, there is dyspnea with feeding, failure to thrive, frequent respiratory infections. By physical examination, there is varying degrees of cyanosis, signs of congestive heart failure, tachypnea, dyspnea. The peripheral pulses are bounding with wide pulse pressure, hyperactive pericardium. The apical pulse is displaced laterally. There is single second sound, systolic murmur or VSD, early diastolic murmur of the truncal valve regurgitation may be audible. ECG shows a normal QRS axis biventricular hypertrophy in most cases. Chest X-ray reveals cardiomegaly with increased pulmonary vascular markings. Right-sided arch may be seen in 30% of cases. Echocardiography is diagnostic by a large VSD seen under the truncal valve, large single arterial trunk with the characteristic pulmonary artery branching pattern according to the different types. It also shows the type of truncal valve pathology, the number of sinuses, whether it's bicuspid, tricuspid, quadricuspid, shows the absence or presence of stenosis or regurgitation in this truncal valve. Right, aortic arch can be also present. Other studies, cardiac catheterization may be indicated if the patient is presenting late to study the pulmonary artery pressure and the pulmonary vascular resistance. So what happens for these patients if left untreated? Mostly they are presenting with congestive heart failure within 2 weeks of life. 85% of cases, if left untreated, died by the age of 1 year. Clinical improvements will develop if the patient starts to develop pulmonary vascular disease by the age of 3 to 4 months of age, and then death will occur by the third decade of life from Eisenmenger syndrome. Truncal valve insufficiency will worsen by time. Medical management of these patients include vigorous treatment with anticongestive measures like diuretics and ACE inhibitors. The condition is associated with DiGeorge syndrome in some cases, so we need to assess serum calcium, magnesium. In case blood transfusion will be needed, or irradiated blood product should be given. And because these patients are usually thymus-based immune deficient, treatment prophylaxis of pneumococcal and streptococcal infections are important. Prophylaxis against infective endocarditis also should be indicated. Surgery should be done within the first weeks of life before the patient develops pulmonary vascular resistance and after medical stabilization of the general condition. For all cases, the VSD should be tunneled towards should be closed so that the left ventricle ejects the blood into the main arterial trunk. For type 1, where there is a main pulmonary artery arising from the trunk, it should be disconnected from the trunk and connected to the right ventricle by a homograft, like a duct. Type 2 and 3, the area of the trunk with the pulmonary artery branches, either from the back or from the sides, will be removed, mobilized, and connected to the RV with a valved conduit. And the aortic continuity should be restored by a tubular graft. The truncal valve should also be repaired, and if repair is not suitable, is not successful, the condition may end up with tubular truncal valve replacement, which carries the risk of mortality up to 50%. The next defect is single ventricle, which represents less than 1% of congenital heart diseases. In this defect, both tricuspid valve and the mitral valve are connected to a main single ventricular chamber. This chamber, in turn, is connected to another smaller rudimentary chamber through what we call a bulboventricular foramen. It's something like a VSD. One great artery, whether pulmonary or aorta, arises from the main chamber, and the other arises from the rudimentary chamber. In 80% of cases, this main chamber is usually the left ventricle, what we call a double inlet left ventricle. This defect is associated with malposition of great vessels in 85% of cases, pulmonary stenosis or atresia in 50% of cases, and aortic arch anomalies in some cases. The bulboventricular foramen, which is a VSD, as we said, is usually obstructed in nature. Sometimes there are abnormalities in the mitral or tricuspid valve, whether it is stenotic or overriding or straddling. In this disease, there is usually mixing at the ventricular level. However, the saturation is determined by the pulmonary flow according to the presence or absence of pulmonary stenosis. Or atresia, if it is present, then there is decreased pulmonary flow with cyanosis and saturation less than 85. If the pulmonary valve is atretic, this represents always by birth. If the pulmonary valve is not stenotic, then the pulmonary blood flow will be large, and there is signs of congestive heart failure very early in life, and saturation is usually above 90%. Clinically, these patients will develop by variable degrees of cyanosis since birth. If there is increased pulmonary blood flow, there will be history of congestive heart failure manifestations like failure to thrive and repeated chest infections. By physical examination, it depends according to the magnitude of pulmonary blood flow. If there is increased pulmonary blood flow, there will be mild cyanosis, maybe unnoticed, manifestations of congestive heart failure, and growth retardation. The second sound is usually single and loud. There may be a long systolic murmur of the relative pulmonary stenosis due to overflow across the pulmonary valve. There is the systolic murmur of the pulmonary regurgitation as a result of of pulmonary hypertension. With decreased blood flow, there is moderate to severe cyanosis. There may be clubbing in older children, single loud second sound, ejection systolic murmur of the pulmonary stenosis. ECG shows unusual ventricular hypertrophy pattern with similar QRS complexes all over the pericardial leads. So there is no pathognomonic right ventricular or left ventricular hypertrophy manifestations because there is no differentiated ventricle. There may be either first or second degree AV block. Arrhythmias may be occurring in ECG tracing, like SVTs or wandering pacemaker. Chest X-ray may show either increased heart size and pulmonary vascular markings in cases of increased pulmonary blood flow. In case pulmonary blood flow is normal or decreased, the heart size is normal, and the pulmonary vasculature is either normal or decreased. Echocardiography is the most important diagnostic sign with the presence of a single ventricular chamber with two AV valves opening into it. Other studies include cardiac catheterization if needed preoperatively to assess the pulmonary artery pressure and the size. So the natural history of these patients, if left untreated, patients without pulmonary stenosis, there is congestive heart failure and growth retardation, 50% of these cases will die before the age of 1 year. If there is pulmonary stenosis, cyanosis will increase by time with worsening of PS. Initial medical management of these cases includes prostaglandin 1 infusion in cases with severe pulmonary stenosis, pulmonary atresia, also in cases with severe coarctation and interrupted aortic arch. In patients with congestive heart failure, anticongestive measures will be required. Clearly, this patient is called single ventricle, so it's going into a single ventricular repair pathway. First of all, we should do initial palliative measures to make sure that the patient is ready for the first surgery, which is Glenn. At first, if the patient is having severe pulmonary stenosis or pulmonary atresia, a BT shunt may be required to improve the oxygen saturation. If there is increased pulmonary blood flow, a pulmonary artery bending may be indicated to prevent from developing pulmonary hypertension and pulmonary vascular disease. Also, any aortic arch pathology should be addressed at this period. After the age of 3 to 6 months, this patient is supposed to go for a Glenn shunt. And finally, by the age of 30 years, the patient should go for the definitive surgery, which is the Fontaine procedure. So the last defect today is the double outlet right ventricle, which represents less than 1% of congenital heart disease. In this disease, both the aorta and the pulmonary artery are arising from the right ventricle, with the VSD as the only outlet from the LV. The position of the VSD and the presence or absence of pulmonary stenosis are the basis for dividing the defect, this double outlet right ventricle, into the different types. The first type is the subaortic VSD, which represents 55 to 70% of cases, where the VSD is closer to the aorta rather than the pulmonary valve, and this is the most common type, as we see. 50% of these cases, the subaortic VSD, have right ventricular outflow tract obstruction, so they represent like a Faro type. In 30% of cases, around 30% of cases, the VSD is subpulmonic. Subpulmonic means it's closer to the pulmonary valve rather than the aortic valve. In less than 5% of cases, the VSD is committed to both valves equally. In less than 10% of cases, the VSD is not committed to any of the valves. So according to these different pathologies and the types of VSDs and the presence of pulmonary stenosis, the pathophysiology and clinical manifestations of the double outlet right ventricle presents. First, the subaortic VSD without pulmonary stenosis. It's exactly like a patient with large VSD clinically, presenting with increased pulmonary blood flow, congestive heart failure, and will develop pulmonary hypertension. Cases with subaortic VSD and pulmonary stenosis, what we call fallow type double outlet right ventricle, present clinically exactly like the fallow. Patients with a subpulmonic VSD, what we call Taussig-Blng malformation, the oxygenated blood from the left ventricle is directed towards the pulmonary artery mainly, and the deoxygenated blood from the systemic veins is directed into the aorta, resulting in severe cyanosis. Although the pulmonary blood flow is very high, and the clinical picture here is similar to the transposition of great arch. Usually presents with gross retardation, severe cyanosis. Second sound is loud systolic murmur of pulmonary overflow relative to pulmonary stenosis. And ECG shows right atrial dilatation and hypertrophy, right ventricular hypertrophy. Chest X-ray shows cardiomegaly with increased pulmonary vascular markings, with prominent pulmonary artery segments. Cases of doubly committed or non-committed VSDs usually present with cyanosis of mild degree and increased pulmonary blood flow manifestations. Echocardiography is essential to diagnose the features of double outlet right ventricle with both great arteries arising from the right ventricle, so that the left ventricle has no outflow except the VSD, and there is discontinuity between the mitral and the semilunar valves. During echocardiography, we should properly evaluate the great artery relationship, the size and the position of VSD in relation to the great arteries, and associated anomalies. Other studies, like cardiac catheterization, may be indicated before later stage operations. So what is the fate of these patients if left untreated? Infants without pulmonary stenosis will develop congestive heart failure and pulmonary vascular obstructive disease. If there is pulmonary stenosis, complication of cyanotic congenital heart disease will occur, like the fallow. Patients with Taussig-Blng anomaly are more prone of developing pulmonary vascular disease earlier in life. Patients with associated anomalies will also contribute to a poor prognosis. Management of cases with DORV includes medical management with anti-failure medications as diuretics and ACE inhibitors and digoxin. Surgical procedures includes palliative procedures, either be banned in cases with increased pulmonary blood flow and congestive heart failure, and VSDs are not easily surgically approached. However, whenever primary repair by VSD closure, it's a better choice. Patients with severe PS with undecreased pulmonary blood flow, a systemic VT shunt should be the option of choice until the patient is ready for definitive surgery. Definitive surgeries for patients with double outlet right ventricle depends on the type of the pathology. In cases with subaortic or a doubly committed VSD, an intraventricular tunnel between the VSD and the subaortic outflow is created by a dacron patch. It's simply a VSD closure. In cases of fallow type, the procedure may be just similar to a fallow repair by the VSD tunneling and the PS RVUT resection and maybe PS dilatation or transannular patch. or it may be more complex by tunneling the VSD by intraventricular tunnel between the VSD and subaortic flow, and doing a Rastelli procedure, which is using a pulmonary or homograft conduit, valved conduit between the right ventricle and the pulmonary artery to bypass the pulmonary stenosis. In cases with subpulmonic VSD, what we call Taussig-Blng anomaly, surgical repair should be done as early as possible to prevent the pulmonary vascular disease. In this pathology, repair is done like the subaortic or doubly committed VSD by intraventricular tunneling, and thus we change the pathology as if it is a transposition of great arteries. So we go on for arterial switch operation also. This is a very tough procedure, and it carries a risk of 5 to 15% of mortality. This concludes the presentation of the most clinical and most important cases of congenital cyanotic heart you can meet in your practice and how you can manage them. Thank you for your attendance. I hope you have a nice day.